wait, it's not. I'll tell you.
One star.
Yeah. Is it star one? No. Okay, that's not working. Was it star one?
Mm-hmm.
The broadcast is now starting. All attendees are in listen-only mode.
All right, hello and welcome to the 5th webinar in our series on antibiotic stewardship, tracking antimicrobial use and outcomes in the nursing home setting. I have a couple of announcements before we get started. You'll receive an evaluation via email after the webinar. You'll need to complete and return it in order to receive your certificate. If you have any questions during the presentation, please submit them using the questions button so our presenters can answer them at the end. Now it's my pleasure to introduce Dr. Erin Epson from CDPH. Erin?
Great. Thank you, Casey, and all of our partners at CAF. Thanks to all of you for joining us again today. This is Erin Epson. I'm a medical officer and assistant chief with the Healthcare Associated Infections Program at CDPH. And see if I can advance this slide here. I'm having trouble. Oh, okay. So today's session is focused on tracking antimicrobial use as well as outcomes of stewardship in the nursing home setting. And we've divided the session into two parts. The first part is going to be presented by Vicki Keller, who's a very experienced infection preventionist who leads our HAI program's Liaison Infection Preventionist program. And she's going to discuss conducting surveillance for HAIs as process and outcome measures that are really a critical component of antimicrobial stewardship programs. The second half is going to be presented by Mike Smith, who is an independent sales agent, well known within the CAF community for his work with long-term care and post-acute care providers to move them forward with electronic medical records and related technology solutions. Mike is going to explore some of the ways that various electronic medical record systems can be used to track and generate reports on these measures. So with that, I will introduce Vicki Keller. Thank you, Vicki.
Thank you, Dr. Epson. It's a pleasure to be here with you today. We're going to be talking about antibiotic stewardship in nursing homes and the vital part of conducting surveillance. So I guess if I had to, we have to go back. I skipped a slide here. Pardon me. I'm not seeing the, there we go. There we go. I'm there. I'm there. The technology is, there we go. So our objectives today, we want to describe the surveillance process and outcome measures, and we'll get into definitions of those, for your antimicrobial stewardship program and infection prevention in nursing homes. We also want to review the basic surveillance practices of data collection, data recording, your data analysis and interpretation, and some of the communications that are necessary once you have your surveillance findings. I guess if I had to pick my most important slide, or I won't say favorite slide, but the slide where I really want you to get it is this slide where we talk about healthcare associated infections, or HAI, and how that relates, that surveillance relates to your antimicrobial stewardship program. It is important to understand that good surveillance is an integral part of an infection or of an antimicrobial stewardship program. You know, we talk about process, and that's what we're doing, the things that we're doing, our interventions. And we talk about outcome measures, which are our infections, and we'll go in more detail on that in later slides. But these are critical components to your antimicrobial stewardship program. This is actually how you identify problems with in your facility, and this will guide you in your practice changes, your interventions, and as you create new policies. So an example might be within your facility, you're looking at the overuse or inappropriate use of antibiotics, such as ordering antibiotics perhaps for asymptomatic bacteria. We know that many elderly residents are colonized with perhaps, we'll say E. coli or some other organism, colonized with that perhaps in the bladder and not infected and don't need antibiotics. But we know that indeed antibiotics oftentimes are ordered for these type of situations. It is by performing good surveillance that you can track the impact of your interventions that you have implemented over time. You cannot know if an intervention or if you've had improvement if you've not tracked your processes and your outcomes over time. And that's very important. Next, it's necessary to generate data or to run reports, and most importantly, to give that feedback to your staff or those that can make a difference, to engage your clinicians and your staff, especially your frontline staff, and maintain their awareness of any infection or practice issues. You know, we've visited with our liaison team in nursing homes, acute care hospitals as well, where the frontline staff aren't even aware that there's an infection problem or that there's a problem with the practice. It may be that's the way they've always done it and no one's ever told us differently because surveillance wasn't being done to take on those issues. Monitoring clinical outcomes of antibiotic prescribing in your HAI surveillance might include things like reviewing your facility's C. difficile infections, for example. So you notice maybe that you're seeing an increase in your C. difficile infections, or perhaps in your antibiotic resistant organisms, you might want to look to see if they're related to a commonly used antibiotic. When you do surveillance, you're looking at these cases and, for instance, are fluoroquinolones being overused or prescribed more often, or is it when you see C. diff or a resistant organism, fluoroquinolone is what was involved more often than not? These are the things that surveillance would help you identify. Another thing you might want to do in your surveillance is to see if you're seeing more resistant pathogens in your urine cultures than in the past. For example, not just simple E. coli, but perhaps some of the extended spectrum beta-lactamase or ESBLs. Or maybe you're seeing CRE and you never saw that before. If you're not doing good surveillance, you might not catch these things. So monitoring these things and then reporting them will demonstrate the impact of your antibiotic stewardship activities on patients or on residents' outcomes, the infections. We're going to talk more about that. So I lost the button down there again. So let's talk about surveillance. Surveillance is defined as the ongoing systematic, and that's really important to understand that, systematic collection and recording, analysis, interpretation, important, and dissemination. And we'll get into dissemination in a minute, but dissemination of data. Surveillance reflects the rate of disease onset or the current health or disease status of a community or population. So in our case, it would be the population of our residents, the health care of our residents. Surveillance aims to identify risk factors for disease. Who is at risk within your population? And it's used for public health action to reduce morbidity and mortality to improve health. So you can see the general definition of surveillance applies to all that you're doing in long-term care as well. This is a slide I've used very often as very good demonstration of what we call the surveillance system as an informational loop or as a cycle. And it starts and ends with communication and action. So let's look at this, the flow of surveillance data. At the top you see collection. So we're out there collecting data. We're collecting the number of infections, let's say UTI, the number of urinary tract infections or central line infections or C. difficile infection. We're collecting data. You're collecting things like the number of patient days. You're collecting things, the number of patient days, the number of infections, all these data that you're collecting and writing down somewhere, which takes you around the loop down to where we talk about collation and recording. So you're collecting these data and you're reporting them into a logbook or into some kind of a database. Maybe it's Excel. We're going to talk about another type of database reporting in just a few minutes. But so you've collected these data and you're reporting them diligently to someplace, right? You're writing them down and putting them, but that's not the end of it. We go around the corner of the loop and we talk about analysis and interpretation. You're not just reporting numbers, the numbers of infections. What good is that? You want to take a look at that over time. You're going to analyze the data and do an interpretation. For instance, you may see that you have been implementing some things to prevent urinary tract infections on patients that have urinary catheters. And you have implemented some interventions, and you can see over time that your rate went down. And so you would be able to say, gee, look, at the time we implemented these, that's when our rates went down. That's some type of an analysis. Or perhaps your rates go up at the time you have a lot of agency staff that are working with patients, or something along that line, some type of way of analyzing the data and doing an interpretation to see where you are over time compared to where you were in the past. It doesn't stop there. The piece that often gets missed, go up and around to the left where we say dissemination and utilization. How are you using those data? We call that data for action, right? You've got data, you can show that your infection rates are, let's say, up for C. difficile, for example. You can see that your infection rates are up, and if you stop right there, nothing will ever be done. You have to disseminate these data to your, more than just your medical staff and more than your administration and your committees, but to the people that can actually make the difference right at the front line caring for your residents or for your patients, and involve them as in the data collection analysis, involve them in the dissemination, because that's where you're going to make the difference at the bedside with the resident or the patient. And of course you're going to implement changes again, and then it comes back around to the data collection. So this is an excellent slide for demonstrating that basically where we fall short is in dissemination of the data. The people that can make the difference need to hear it. What's the end point of surveillance? Well, hopefully progress in your HAI prevention. This is just an example in our little fake hospital we created here to show that at the bottom we're showing the months over time for CLABSI, central line associated bloodstream infection, from 2009 to 2011 in our little hospital here, and we can see that something happened in July or September where there was a spike in infections, and we implemented an intervention, and we can see over time that this hospital has been able to maintain a lower rate of CLABSI in their facility, and that's what you want to see over time. But you won't know that unless you're tracking it and reporting that out and talking to your staff about it. So what is quality surveillance? We have some key tenets. You have to have a written plan, right? Every facility should have a written infection prevention plan, and it serves as the foundation for all of your activities. So what am I tracking? That should be in your plan, and why? We're tracking UTI this year because last year we saw a spike in our UTI, or we're tracking UTI because we have a large number of residents that have urinary catheters and they are at risk, right? How will the data be used? You're going to use that to focus where your infection prevention activities are going to be, right? Or where you need to put more resources. And then where are opportunities in my facility after you've written your plan? Where are the opportunities in my facility where I see that we can make an impact or make a difference? You should make sure that the intensity of your surveillance, it needs to be maintained over time so that you're not taking just 1 month where you're really watching and looking and doing surveillance and then you let it go for 3 months or 6 months. If you're going to be doing surveillance, you need to do it consistently over time and apply the same surveillance definitions every time. We're going to get a little more into definitions as we move forward. But those are your tenets: a written plan, maintain your intensity, and your consistency over time. So HAI surveillance in long-term care, what does that mean? It means when long-term care facilities track HAI, they have identified problems to plan targeted prevention efforts, right? So they know where the infections are, and they're going to target that area to work for prevention. They're going to track progress towards preventing infections over time. They know that good surveillance requires consistency, and we spoke about that. Many of you, if not all of you, are familiar with the McGear criteria, and that is the criteria or definitions that are used in long-term care. You'll see in the next bullet there we talk about the National Health Safety Network, NHSN, and you may hear people talk about NHSN definitions. Well, NHSN has specific definitions for many infections, but they provide a system specifically for long-term care facilities. There's a long-term care module to perform and monitor your HAIs. So they use the McGear's definitions. So if you hear someone say, well, I won't use NHSN because we have to use McGear's definitions, in the long-term care module, NHSN does use McGear's definitions specifically for long-term care patients. And each long-term care facility data that is entered into NHSN helps you to establish benchmarks, right, so that you can interpret your rates over time and then gauge your progress toward the HAI prevention goals in the nation to see how your facility compares to like facilities within the nation. And that's really what you want to do. There's two things you want to know as you're doing surveillance. How is my facility doing over time? Am I doing better? Am I doing worse with my infections? I implemented some interventions, and I want to know, did that make an effect in making our infections come down? We made an antibiotic stewardship new policy on how we're going to approve antibiotics to be used. That might be one example. And has our infection rate gone down? And if you don't have good surveillance, you won't know if your ASP, your antibiotic stewardship program, is effective or not. So you need good surveillance to know that for yourself over time, and to see how you compare to other facilities like yourself throughout the United States. This is a screenshot of the NHSN long-term care module and the types of things in your surveillance that you can use. The upper left shows the MDRO, multi-drug resistant organism, and the C. difficile module, and this is surveillance, as I said, for C. difficile, MRSA, and other drug-resistant infections if you choose. This is all by choice. And there's lots of training. The protocols are there to give you the correct definitions and how to do correct reporting. There are data collection forms, I'm going to show you one in a moment, and other supporting materials to help you in your surveillance endeavors. And there's some analysis of resources there and frequently asked questions. And right below that you'll see for UTI, reporting urinary tract infections, the same thing. To the right at the top is a nice module that is in there for reporting prevention process measures such as hand hygiene. So you have a place that's specifically designed for hand hygiene and another one for gloves and gown adherence for your PPE. And you can do your adherence monitoring and report it into there and get nice charts and graphs and feedback along with supporting materials and data collection tools for you, all within this long-term module, long-term care module. And at the bottom you'll see a link there that you can click onto. The cdc.gov, NHSN/LTC for long-term care. You don't have to be enrolled into NHSN to be able to use these tools or these supporting materials or the data collection forms or to look at the protocols or training. You do need to be enrolled to be able to use the analytical features that I'll show you in a minute. But if you're not sure what you want to do or you're just looking right now, you can go to that website and take a look at the tools that are there for you. Very good tools. So let's talk about what we recommend at CDH and CDC as well, recommended practices for surveillance. And you can see at the bottom right, the American Journal of Infection Control. If you belong to APIC, that's their journal, recommended these things for a robust surveillance program. You want to be able to assess your population. You have to be able to select the outcome or processes for surveillance. We'll talk about that. You want to use surveillance definitions and, of course, use them consistently. You want to have a process for collecting surveillance data. You need to be able to calculate and analyze infection rates. Don't get scared off. We're going to show you some of that. Apply risk stratification and methodology, and NHSN does that for you. I'll show you that in a moment. And then report and use that surveillance or data for action, if you will, in your facility to be able to make a change. So we're going to go over each one of those. So assessing your population. So you have to know your population at risk. Do you know what infections occur most commonly in your facility? Okay, and what infections are likely to occur? So what infections occur most commonly and what infections are likely to occur if you haven't seen them yet? Flu season's coming up. You might want to think about that. You may not have that the other part of the year, but come fall, that's likely to occur. What types of patients are most at risk for infections, right? Maybe those patients that have some type of device, right? Medical conditions or devices like ventilators. Some of you may have ventilators in your facilities. Certainly urinary catheters would put them at greater risk, right? Or central lines. PICC lines are considered a central line. So where are the greatest opportunities to improve antibiotic prescribing and or prevent infections? This is what you're going to decide with your team. Where are our greatest opportunities to improve antibiotic prescribing and prevent infections? Perhaps that is, you could begin with those bacterias, the E. coli in the urine of a resident that has absolutely no symptoms but gets put on antibiotics. That might be something you want to look at in the beginning. You'd have to choose that within your facility if that's an issue for you. Recommended practices for selecting the outcome or process for surveillance. So let's talk about that. What does outcome and process mean? I know when I first was learning to speak the quality words that they use in hospitals, that was sort of confusing. Simply put, an outcome is the result of your care or performance, or some type of care or performance. For instance, infections are an outcome of maybe poor care, right? So infections such as C. difficile, we report that as 10,000 resident days, right? Infection count per 10,000 resident days. Antibiotic resistance. So if you have rates of infection with multi-drug resistant organisms, that's an outcome. That happened because of something. You have a higher rate of multi-drug resistant organisms, or MDROs. The percent of organisms susceptible to antibiotics. Perhaps in the past, your antibiotic that was most used for UTI was always susceptible, but for some reason all of a sudden it's becoming more and more resistant. That's an outcome. Or antibiotic adverse events are all outcomes of misuse, possible outcomes of misuse or overuse of antibiotics. So what is a process? Well, the process is the series of steps that result in an outcome, the things you do that result in an outcome. So we'll take this on a positive note. So adherence to policies and recommended practices. So we're doing all the right things. That's a process. The facility-specific treatment guidelines for infections, those are processes. Your CAUTI prevention, you're tracking and trying to make sure that the percentage of urinary catheters are appropriate. That's a process. Immunizations are a process, right? So a poor outcome of a bad process, if you're not immunizing, you may have patients that get flu or pneumonia. So that's the process. So number 3 is using surveillance definitions. We talked about McGear's, but you want to make sure that you are always referring to written definitions to ensure accuracy. We underline written definitions. You don't want to, put these to memory. As often and as long as I've been doing this within acute care hospitals and long-term care and all the different types of infections that are out there, you want to make sure that you're using a standardized, published, validated set of definitions. And if you don't have a definition for a specific type of infection, can't think of one offhand because most people do, but if there's not a definition that's written that's available, prepare some type of written definition within your policy to ensure that everyone within your facility is using the same definition for that type of infection. And it's important for accurate and valid comparisons that you use the same definitions, as we've said. If you change the definitions, the comparability of rates over time is going to be compromised. And that could happen whether it is nationally, on a national level, or if you change the definitions within your facility. Let's say you decide at your facility to change the definition for UTI, let's say. You're not going to be the same, compared the same as what you were a year ago because you had a different definition. You may have had your rates go up or down. And if you're within a corporate entity, your facility isn't going to be measured the same as other facilities if you change the definition. It's really important that we're all staying on the same page and using the same definitions. I've stressed that because it's so important. This is an example. It's actually a screenshot of the surveillance definitions of infections in long-term care facilities. This is available through the Infection Control and Hospital Epidemiology SHE position paper. It's also available on our website, and I believe within the NHSN. They used to have it within the NHSN long-term care as well. But I put this here so that you can see where you can find it. You can also, you can Google it. It'll come up. You'll be able to find it. It's on our website, CDPH website, which we'll show you later under the long-term care section. We have it available for you. But these are standard definitions that have been specially developed for long-term care facilities and the type of population that you have that's at risk. So applying the definition. So for instance, we're going to talk about UTI. In long-term care, UTI in a long-term care facility, there are 2 types. There's a urinary tract infection, and then there's a catheter-associated urinary tract infection with different criteria. The definitions include laboratory criteria and something we call constitutional criteria, which includes fever, leukocytosis, which is a high blood count, white blood count, and acute change in mental status from baseline, because we know that some people have an altered mental status consistently, but a change from baseline, or acute functional decline suddenly. So if you have a sudden change, that might be something that would be constitutional criteria. And again, at the bottom, that's the link for you, not a link, but the information for you to be able to find the surveillance definitions for McGear's criteria. This is an example from NHSN, the website that I showed you earlier. It's a paper worksheet that you can print out. That's just part of it here. You'd have to go to the website to print it out in whole. But you can see where the events details, if you're collecting data, let's say someone on your unit floor level is collecting data for you. And they can check off here, was there a fever within those parameters? Or were there rigors or new onset of hypotension, or all the symptoms, symptomology. And if you look below, new and or increased, check at the bottom there. Urgency, frequency, incontinence, all the symptoms that are part of the McGear's criteria for a urinary tract infection. To the right, you see laboratory and diagnostic testing. So you would check off, all those that would apply. The specimen was collected clean catch and they have a white count, the positive culture of greater than 10 to the 5 on 2 specimens or more. Remember, you need 2 specimens, not 2 specimens, with no more than 2 species or organisms in the specimen. If you have more than that, it's considered to be contaminated. I won't go into all the details here, but this is an example of a worksheet that someone at the unit level can check off all those that apply, or you can do it by looking back at their record and then go back to your NHSN definitions and determine if indeed they meet the criteria for an infection. So this is an optional worksheet. You should have some type of worksheet. This is just an example. So what are some of the recommended practices for surveillance regarding collecting surveillance data? Well, I know the first thing is you're not alone. Data collectors should include infection prevention staff, so that might be your DSD, or it might be maybe you're lucky enough to have a full-time infection preventionist, but others that are responsible or interested. You may have some other people that are interested in infection control that can collect some of these data for you. Right? But please limit the collection to only what you need. Collecting data for data's sake is a waste of time, and people will fatigue from that early on. So you want to make sure you limit it to only what you need for your specific focus. And you want to be involved in efforts that advance the electronic health record. And I can't stress this enough. If your facility isn't already, but if your facility is moving to an electronic medical record, be sure that whoever is involved in infection control, whether it's a DSD or an infection preventionist, whoever that is involved in the planning of that electronic health record. There are things for data collection that you're going to want to collect that'll be much easier if you can do it electronically. For instance, does the patient have a urinary catheter? Does the patient have a central line? And make that not just an optional field, but one that has to be checked off so that you know consistently that it is being looked at the unit level. That's a very important one. So we talk about numerator and denominator when we're talking about infection rate. So what does that mean? The numerator is the infection. That's the event that's being measured. An example would be an HAI through active surveillance would be if you're looking at a CAUTI, a CLABSI, a CAUTI, a surgical site infection, or a ventilator pneumonia. Those are the infection. That would be the event. That would be your numerator. For HAIs that you are collecting and looking at just from laboratory results alone, that would be a C. difficile, CDI. Your MRSA bloodstream infection or VRE bloodstream infection, those are collected and reported into NHSN just by the date of admission and the date of the specimen collected. A numerator can also refer to your care practices or processes. So a central line insertion practices, the elements involved in that can be a numerator. Or how about hand hygiene compliance? So hand hygiene compliance numerator would be the number of times someone correctly did hand hygiene divided by the number of observations that you did, which would be your denominator. And we're going to go into that next. So your denominator data is the population that's at risk, the total of all possible events. So for instance, if you were doing surgical site infections, your numerator would be the number of infections and your denominator would be the number of procedures that were performed. So if it was an appendectomy, I know you're not doing those in long-term care, but it could be some type of procedure that you would perform divided by the total number of procedures that were done over a period of time. Or it could be the resident days if you're talking about C. difficile. or resident admissions. The total urinary catheter days over a given period of time. So the number of infections, UTI, would be your numerator, but the number of urinary catheter days would be your denominator. And then when you calculate that, we're going to get into that for calculating and analyzing infection rates, you want to apply a risk stratification methodology, and we're going to show you what that is right here. So don't let this scare you. It's math. Don't let it scare you. It's actually quite simple once we've explained it. You have your total population at risk, right? That's your denominator. You want to use this to calculate a raw rate, or what we call an incident density rate. Don't get confused by that. But for C. difficile, it might be 5 C. difficile patients, and you had 300 patient days, and you would multiply that by 100. Actually, within some databases, they multiply it by 1,000. The only, or 10,000. The only reason you multiply that number really is to get a whole number, so it'd be the number, your numerator is the number of CDI, the denominator is the number of patient days, multiply that by 100, and you have a rate of 1.67. For CLABSI, in this particular time frame, we had 2 CLABSI, that's our numerator, divided by the patient or population at risk, 150 line days, multiply that by 100, and you have a rate of 1.33. Very simple. The one at the bottom, we talk about central line days, but this can also be used for urinary catheter days. So we have 150 patient days that had a central line divided by the number of patient days. That'll tell us the percentage of patients that had a central line. So in this case, 50% of the patients had central lines. That's what we call our device utilization rate. Again, don't get confused with the nomenclature or the words. It's just saying 50% of the patients had central lines. That's high. And if 50% of the patients had even Foley catheters, that's really high. It's something you want to look at to reduce over time. All right, report and use surveillance information. How do we do that? I love this quote, again, from the American Journal of Infection Control. It says, the demonstrable power of surveillance is in sharing findings with those who need to know and those that can act on the findings to improve patient safety. It doesn't do you any good to report a lot of numbers to someone that can't do anything about it. So you have to plan for your distribution of your findings after you've been doing all this good surveillance work. You want to report to healthcare providers that are most able to make an impact on patient care, whether it's your infectious disease doctor, probably, or your medical director, someone that can be a champion to help you make the changes that you need to make in your facility. Certainly it might be your pharmacist, if your pharmacist and your ID doctor are working with you, whoever's helping you with your antibiotic stewardship program in these things as they relate to infections. You want to report in a manner to stimulate process improvement. So that means making it interesting, using charts and graphs or tables or something with a visual that's pleasant to look at and not just a list of numbers that's going to get lost in a sheet of paper somewhere. I'll show you what that looks like. This is one example. And within NHSN, in the analysis part of it, you have a place where after you've entered in your data, you can actually create charts and graphs, or if you like Excel, you can take the data that you've entered in each month, you know, the number of patient days, the number of line days, the number of catheter days, and actually print out, and you're going to look you're going to feel so good and look so smart when you present these to your infection control committee. This particular example is a bar chart, and it's the location of onset for CDI it's our XXS long-term care. It's a pretend hospital, pretend long-term care. But at the bottom you can see where you can track the community onset percentage, the acute care transfer percentage, and I'll show you what that means in a minute, long-term care onset percentage, and recurrent, those that have a recurrent infection that's ongoing. And instead of just looking at numbers, you can create something that's much more visually impressive, right? The next slide, just some more examples. The top one shows the 2013 long-term care facility overall CDI rate and the facility onset rate. So overall, we see in the first quarter of 2013, in the blue is the total CDI rate, and the red is the long-term care onset rate. Now, you're not having to create these. The only thing you have done is enter your data each month, and then you can run these reports later on or send them out to Excel to do exactly that. The bottom one is just showing a pie chart. Now, doesn't that strike you interesting in an interesting way when you can see the onset of CDI in this facility? 50% of these onset of CDI were onset in the long-term care facility. we can see that 35% actually were those that came from an acute care hospital. They got it when they were, the specimen when they came into the long-term care, but they actually the infection is attributed to the acute care facility. This is an example of entering data into NHSN, the database. The top part there is just where your hospital ID number would be, and if you wanted to put the patient name, you could, or you could just use a medical record. But the piece where we talk about entering infections, it prompts you for the type of infection that you're going to report. So in this one, you're going to report a UTI, and then it says, was there a catheter in place and on what day? So they know how long it was in. And then on the next sheet, going further down, as you report, you're going to click on the symptoms that helped you to apply the definitions. You can see up there, this particular patient had a fever, they had positive blood culture, and the specimen was collected from the indwelling catheter. We see that. Now, what I like about NHSN, it will automatically populate the field with the correct infection type. So was it a catheter associated, or was it a UTI, or not? And it knows the dates that you have put in and the symptoms that you have put in, so it won't let you put it in error. And at the bottom of the screen, you can see there that they ask for what type of pathogen. This is really important that you put the pathogen in there, and when they ask for what drugs were effective, or the susceptibility or resistance pattern of these, that you plug those in to the NHSN database for your antibiotic stewardship purposes later on. This is just an example of creating something called a line list. So you've put into NHSN that I'd like to see all the C. difficile infections for 2000, in this case it was 2013, and run a line list, and look what it did on the right there. It tells you which ones were long-term care onset and which ones were actually acute care onset that happened in your facility, but we know that they came from acute care. That's an interesting one, and you can make pie charts and graphs about that like I showed you earlier. This is just another way of looking at CDI rates for this facility by quarter. You can see to the far right on the top there that each quarter we had a problem in quarter 3. Remember, we looked at that bar chart where we can see that we had a CDI rate of 10.24 during that 3rd quarter. And we implemented some good hand hygiene and some other things, and good antibiotic stewardship program was implemented, and we were able to bring that rate down. Looking further down at the bottom, we can see that in quarter 4, 50% of them were community onset, and then the bottom chart, you can actually run a report that'll show you the percentage of long-term care or acute care. It's just different ways for you to do this. So in summary, it's very important that you understand that processes and outcome measurements are critical components of your antimicrobial stewardship program. You're going to implement these antimicrobial stewardship interventions, and you have to be able to measure what your outcomes are, meaning your infections. So antibiotic stewardship really does include a robust HAI surveillance program, and consistently applying the HAI definitions is necessary, and in long-term care that would be your mid-years criteria, but being consistent in your case finding. NHSN is a database for collecting data collection. I don't work for NHSN. It's free. It's through CDC. But the data collection, the analysis features, and then comparing your facility to like facilities is the way that you're going to be able to see the evidence and the effect of your antibiotic stewardship program. And of course, sharing your surveillance findings with those who need to know and who can act on the findings is important for you to improve the outcomes that you're looking for. And with that, I will turn this over. We're going to take questions at the end of the program. You will see our website there for questions, and or our website if you want to go to the long-term care and to the antibiotic stewardship program information. I'm going to turn this over. Should this be where we are, Erin?
Thank you. Actually, Casey, I'm wondering if you can tee up the polling questions.
Okay.
Yeah, so thank you so much, Vicki. And yes, we're going to do Q&A at the end, and so everyone just jot down your questions for Vicki or write them into the questions part of the webinar, and we'll try to get to them at the end. And certainly, if there are remaining questions that we don't get a chance to get to, we can certainly follow up on those afterwards. So a couple of, we're going to precede Mike Smith's presentation and the second half of the webinar with a couple of polling questions just to get the conversation started. The first is, does your care center use an electronic medical record? Please take a moment to...
An opportunity to answer. We're about 45% of you voted.
Okay. Give it another moment.
Yeah, fine.
Okay, we're going to go ahead and close the poll now and show the results.
Right, wow, 80%. Great. Well, so then that 80% of you, please answer this next question. Wait for that to come up. So you do have an electronic medical record. How are you using it? Do you use it to track infections or antibiotic use, and have you used it to generate summary reports? Please take a moment to answer that.
So we're going to close this, Erin.
Yes, please go ahead.
And then there's the results.
All right, so just a little under half, so that's interesting. Well, you know, Mike Smith is going to address those functionalities of electronic medical records, and I think we'll turn over the presentation to you.
Great, thank you, Dr. Epson. Good to be with you all today. I'm going to talk to you about electronic medical records. Vicki alluded to it through her presentation, and what I'm hoping to accomplish with you today, I've got a couple of agenda items here. The first one here is to understand the ways that EMRs can be used to track antimicrobial stewardship metrics, these metrics that you're going to be focusing on. And then I'm going to give you some examples and functionality and reporting that can be generated by an EMR. So what I hope to do is really share with you some of my experience, and actually a couple of EMR vendors were kind enough to share screenshots and some reports that I think will be helpful as we go through this. But just to give you some guidance and some thoughts about when you go to your facilities and you're back to your facility and you're talking with your staff and you're working on solving this issue, you know, how you can implement that. So I want to first start off and give you the benefits of electronic medical records. And I was glad to hear that, you know, 80% of you are using electronic medical records, and I realize that could be a whole range of you know, how much is being used, but at least you've got some familiarity with electronic medical records. But it's important to kind of set a baseline for why is electronic medical records important. Sometimes we do things because it's, you know, we're required to because of our company told us to do so, or it's a standard company-wide. But there are some really good benefits that just make it easier to adopt new technology once you understand that. So the first one that I have here is electronic charting, and that allows you to capture discrete data. So rather than writing things down on paper and you know, going to that chart to extract the data, it gives you the ability to pull the data and use it in a meaningful way. It gives you timely access to data as needed. Vicki talked earlier about, you know, once you've got the data, being able to disseminate that out to your staff to be able to take action and you know, solve these problems. An EMR, assuming you have devices that are available for your staff to access, gives multiple people access to the same information rather than, you know, having that backlog of waiting for a chart or waiting to get to a particular file. They can just view it as needed. So that's a really important you know, aspect of electronic medical records. And then, in general, it's a tool to improve the quality of care. So, sometimes that exhibits itself in terms of the workflow. Sometimes it frees up staff, not always, but sometimes it frees up staff through efficiencies in the workflow to maybe spend more time with the patient or with the family. And so there's some inherent improvement in quality there. There are many systems have alerts and notifications. So it's some sort of artificial intelligence to help the caregiver to know when to do certain things and how to follow up, and then when certain events happen, certain conditions, there's protocols on how to deal with that. Particularly as we're talking about infections, antibiotics, there's a standard or a protocol that needs to be followed. So EMRs have the ability to help manage that whole process. And then the last one there, as far as the benefit, is the reporting aspect, and that's really kind of the big payoff of the time and the effort that's spent in collecting the data, is that you now have the ability to do a data analysis, to see how you're performing, where you're hitting the mark, where you're missing the mark, and you can do quality improvements and those sort of things. You can look at trending and tracking outcomes, not only on an individual patient basis, but across your facility, across your whole organization to improve the outcomes. So what I decided to do that I thought would be effective was to look at the CDC recommendations, and these were, Dr. Epson sent these to me, so these are those recommendations as it relates to the Antimicrobial Stewardship program, and I've listed them here, and I'm going to go through each one of those, and I'm going to give you examples of electronic medical records that are doing either can solve these particular metrics, can help you get the data for these particular metrics, or maybe they get you close. And so first thing is that no EMR is going to do everything right out of the box, and we'll talk a little bit about that. It may not produce all the reports that we just saw with the NHSN, but it may be enough to to get you close to those numbers if you decide to use your EMR for that. I've got a couple of vendors that were kind enough to send me screenshots and reports, and just know that I don't sell these EMRs. I have sold electronic medical records and EHR for many years, but I don't represent either of these companies, and there's no financial interest or anything in there. But these were the companies that were kind enough to share with me their screenshots, so I'm grateful for that to address each of these items. So the first one that I have here is the adherence to clinical assessment documentation. So it's dealing with signs and symptoms, vital signs, physical exam findings. And if you look at this screen, you'll see that this happens to be for a UTI, and it has some guidelines and some instructions on the upper right corner there. Hopefully you can see my my arrow on the screen. And so those are some instructions there, and you notice that it's got, it says document signs and symptoms of UTI, document vital signs, and it goes on down the list. So this is a set of instructions that is put in front of the caregiver to tell that person, these are the things that you need to do. This is the protocol, or this is the standard that you follow as far as assessing and dealing with this particular infection. So that's built into the system, and so many times these could be guidelines from a national standard that's out there, and I think Vicki may have talked a little bit about this, but it could also be a facility-specific standard guidelines that you want to provide within your facility to make sure that your staff is following up on these things. Okay, and so the next slide is really just one example of a report that is brought to the screen or a view. This happens to be lab results, but it could be anything. So to the extent that an EMR that you may have in place or that you're considering can take data that's being collected, various, from different, staff and different parts of your organization, and bring it together into a format that's easy to read, and to see what's going on with that patient is really important to be able to manage that patient, manage your population. Okay, so the next one here is adherence to prescribing documentation. This is dealing with the dose, duration, and indication. And then there's a second one that I added, both two items on here. Adherence to facility-specific treatment recommendations. So I decided to use a screenshot from an EMR system, which is part of an EMR. I know there's a lot of acronyms here that get a little bit confusing, but this is a electronic MAR, medication administration records, an electronic medication administration record. And so what this does is shows the medication, the dosage, the special instructions, all the information that a caregiver needs to have in order to administer that medication. So that order has been put into the system. It's a physician's order. Someone in the facility is entering that, and this is what is displayed to the caregiver to tell them what medication, when it needs to be administered, the frequency, and all of that is built into the system to automate through alerts and notifications to make sure that the medication gets administered at the right time. So there are a lot of tools built within this one module, and I would say that most long-term care EMRs have something like this to guide the caregiver to make sure that they're administering the medication appropriately. And you'll notice over on the kind of on the right side there, the red buttons that say late. That's an indicator that in this picture that those medications that they were late in administering that medication. So there's some timeliness tools in there for the caregiver. And then some systems will have the ability to put in facility-specific recommendations. So there might be the way that the order is written from the physician, and then there might be some specific standard treatment recommendations that are entered from the facility. This screen here is an example of providing the caregiver with detailed information about the medication itself. So it's much like the physician desk reference, the PDR, where they're able to pull up and look at any medication that they're about to administer or have administered. The staff can pull this up. They can look at contraindications, any safety issues. It's a very, very detailed information. So they can bring that up and view that for themselves, so they're familiar with that medication. But they can also bring up a resident view, which is information that is not as clinical but appropriate for the family and for the resident, and they can print this off. They can get a copy and give it to the family or give it to the resident so that they're familiar with the medication. Let's see. So the next one is point prevalence surveys of antibiotic use, such as on a given day, how many residents are receiving one or more antibiotics. So this is a dashboard, and some of you may have dashboards within your EMR, and really what it does is it takes a lot of data that's been collected, and it just sort of condenses it down to just the basic information that you need to know. So in this picture, we've got some vital signs. It's showing you vital signs, maybe vital signs that fall outside of certain parameters. But there certainly could be, and most dashboards do have some customization capability, but there could and should be the ability to pull the number of antibiotics that have been administered, or how many residents are on an antibiotic at any moment in time. So just having an icon or an option there so that when you pull your dashboard up, you can see how many residents have one or more antibiotics. It's a fairly straightforward view of that. And there might be other reports that can be generated within your system. Here's another one that that could help you get that particular metric, get the numbers for that particular metric. This particular report is an infection log, and this shows all of your residents that have had an infection, what type of infection it was, the related diagnosis, and whether or not there was an antibiotic. And then it goes into disposition and whether it's open or resolved infection. So this particular report, is useful. It may not be the exact report to get you the number, the specific, recommended metric, but it may be enough where you take that information, and this second screen here is a summary of the data down at the bottom. You can kind of see how it's categorized and summarized at the bottom. But you may take data from here and then generate another report, and then together through those two reports you may get the information that you need. So I guess my point here is to say that when you go back and you look at your EMR, it may or may not have exactly what you need. You may have to work with multiple reports to get that, or work with a vendor to help you get the report that you need. The advantage, of course, here, and maybe the difference between the NHSN system, which looks like it does, all of these or a good portion of these, is that what I'm showing you here through EMR, of course, that's part of your medical record. So it would not have to be, keyed in separately. You've got all the same, demographic information, all the same clinical information, all under one electronic medical record. So there are some advantages to using an EMR versus a separate database where you're keying that in. All right, so here we have, we want to capture the rates of new antibiotic starts per 1,000 resident days, and then another one is antibiotic days of therapy per 1,000 resident days. So I pulled up an example of this, this report generator, which is pretty standard. Almost all EMRs have something like this. You all probably use it on a regular basis, use yours on a regular basis. And essentially what you're doing is you're just going in and you're putting in the criteria. In this case we've got ABT, antibiotic therapy or antibiotic treatment, and then you might want to put in a time frame and then generate a report for whatever it is that you're looking for. So again, this may or may not get you to specifically the answer to that particular question, but it'll get you close. Many times these reports these report generators have the ability to export this data to an Excel spreadsheet, and that allows you, once you get it into an Excel spreadsheet, if you have somebody that's good with Excel, to do some further data analysis and data I want to say manipulation, but that never sounds right. But essentially get to the result that you're looking for as far as getting the data that you want. So this is the last three on the list there, the rates of C. diff infection, the rates of antibiotic-resistant organisms, rates of adverse drug events due to antibiotics. Really, the bottom line is looking at your EMR to find out, do they capture this information or not. So if they do, then it's fairly straightforward to get the data out. If there's a place for it to capture it, there's typically a way to generate a report that's going to give you some metrics. So I've got a screen here. It's an infection entry screen. So in this case, we're able to select the resident. We're able to enter the infection within this screen. We're able to answer some questions, and so it has the the protocol or the standards. It's sort of a wizard that walks you through what information needs to be captured. So that's an example of that. And then here's the second tab here. This goes a little bit more into the test and the diagnostics related to that infection. Was it an antibiotic? If you notice down here, it asks, was there an antibiotic, yes or no? When was it started and what type was it? So it allows you to actually select the antibiotic, which should have already been entered in the system, under the physician order modules. Most EMRs have physician orders where the medication gets entered into the system there, so it should tie out. And then a third screen here, or a third tab of this infection entry module, it has, it's asking, is this a reportable infection? Who is it reported to? Who reported it and when? Was the physician notified and when? Was the family notified and when? So it's just walking through all of these steps. So again, once this information gets captured, then you're able to generate a report. There's that report generator. In this case, we're looking at gastrointestinal infections. We want to generate a report to take a look at those within a certain time frame. And here's a sample report. And so this shows you how many C. diffs that we had within a certain time frame. It's got the data up at the top in a grid format, and then it's got a graph down at the bottom. And most EMRs will do something like that, where they have the data in grid format and then a graphical representation at the bottom. So let's see. All right, so that's it with the screenshots and the EMR. I hope that was helpful for you to get some ideas of what you can, what you might consider or kind of what to look for when you go back and take a look at how you're going to implement this program. I want to leave you with some recommended steps and tangible things that you can go, and this may be, you may already be engaged in doing this, but I think it's helpful to step through this a little bit. The first question is to find out what is in place now with your electronic medical record. Talk to your staff, find out who's your best user, who's most familiar with the system, and find out if you have something in there already that is capturing infection and antibiotic tracking, and to what extent. And so if you have it, but you're not using it, and it sounds like about 50% of you are using it and half of you are not using it, then if you have it but you're not using it, I would recommend that you contact your vendor and ask them to refresh your staff on how to use that. Give them, maybe they can do some web training, or maybe have somebody come out on site and do some training to get your staff up to speed on that infection control module that they're that they're not using. You've already paid for it, but you're not using it. If you don't have the infection control module or something to track this information that we're talking about, you should go to your EMR vendor and just find out if there is a module or some component of their software that maybe you haven't implemented yet, but it would be helpful in tracking this information and generating the reports that you need. So you can ask them that, and then you also want to ask them if there is nothing else available, then you can ask them, is there something on their EMR development roadmap? And I think that's a good question to ask, and to try to get what's the timeline, if there is something on the horizon for infection control and antibiotic tracking. Find out, is it next quarter, is it 6 months, is it a year down the road? Just get some idea of any development that's on the horizon. And I think it would be fair to go to them and say, this is a new regulation. It's something that all providers, or at least here in California, collectively, especially if you have a good number of counterparts that use the same system, you can just point out that this is something that all nursing homes are going to be dealing with, and it would be to the advantage of all providers to have a tool to help us track that. And then the last one that I have there is to ask your EMR vendor if they would or could develop custom reports or tracking tools to help you to track this. Maybe most systems that I'm aware of are able to take third-party report writing tools, either within their system or third-party report writers, and generate custom reports to get you the reports that you need. So you might ask about that and see if they can help you out with that. So that's what I have for my portion. I hope that's been helpful. And now I'll turn it over to Deborah, and we'll take any questions from you.
Deborah or Casey, are there any questions? Perhaps in the interest of time, we'll look and see if there's one good question to ask over the webinar, and perhaps then if there are additional questions, send them my way, and I can work with the presenters to develop some responses that we can share afterwards.
Sure thing. Well, I'm not seeing any questions that have been submitted here.
Okay.
So,
well,
yeah.
That's fine too. I think the participants all have the contact information for me, and certainly feel free, or of the HAI program, and certainly feel free to send us any questions that you might have in relation to this webinar, and I can work with the presenters to get some responses out to you all.
Oh, hold on a second. It looks like we do have a couple of questions here. Sorry about that, but okay. First one: if the patient does not meet McGear's criteria, is it not considered a true infection?
That's a very good question. Dr. Epson, do you want me to take that one?
Well, sure, go ahead. I mean, I think that you're getting at the issue of the McGear criteria being a surveillance definition.
Exactly. Go ahead. You got it.
Well, certainly an infection that meets McGear criteria meets a surveillance definition and should be counted as part of surveillance, but whether or not that is an infection that clinically needs to be treated with an antibiotic, that can sometimes be a little bit more of a subtle distinction, and treatment decisions really should be made on the basis of a clinical assessment.
Okay, and we just have one more question. Are the acute hospitals tapped at all about the stewardship program?
Are they what?
It says, are the acute hospitals tapped at all about the stewardship program?
Tapped. Well, acute care hospitals have been required to have stewardship programs for some number of years, and can certainly serve as a tremendous resource for nursing homes and their referral network. And we certainly encourage nursing homes to consider reaching out to their acute care hospital partners, reach out to their acute care hospital and microbial stewardship program leads, and see where they might find some opportunities for consultation or collaboration to develop stewardship strategies that really cross that continuum of care. Some acute care hospital stewardship leads are providing consultation to assist with stewardship program development in their nursing homes that they're affiliated with. So it's certainly a great resource, and we certainly encourage all of the nursing homes to consider reaching out to their acute care hospitals to get some support and consultation and collaborate. Okay, thank you. Well, I want to thank everybody for attending. A special thanks to Dr. Aaron Epson, Vicki Keller, and Mike Smith for presenting today. And just a quick reminder, our final webinar in this series will be held on December 16th. Excellent. Thank you all.
Thank you.